Welcome to AETCM, the Emergency Medicine channel. Today we will be discussing a case of a 34-year-old female who is a known case of diffused parenchymal lung disease, who presented to ER with excessive cough and breathing difficulty since last 4 days, followed by sudden worsening of breathing difficulty for the past 2 hours. On initial 10-second assessment, patient was conscious, oriented and obeying commands, but was unable to complete one full sentence. On primary survey, airway was patent, no gurgling sounds, no secretions or any pooling of saliva was present. On breathing, patient was tachypnic with a respiratory rate of 36 per minute. Saturation on room air was 77% and with 5 liter and it was 95% with 5 liters of oxygen via face mask. On auscultation, bilateral chest movements were decreased, right more than left. On left side upper zone, air entry was decreased and basilar velcro crepes were present. On circulation, the patient was maintaining a blood pressure of 140/90. Pulse rate was 89 per minute. All peripheral pulses were felt. At this point, 18 gauge cannula was placed and cardiac monitors were connected. GCS of patient was 15/15, E4, V5, M6. Pupils were equally reactive and patient was moving all 4 limbs. On exposure, patient was afebrile. GRBS of the patient was 110 mg per deciliter. ABG was taken. ABG showed...
So after the primary survey, what all findings did you get? Patient had desaturation. And air entry was reduced on the
bilateral side, but more on absent on right side.
Absent air entry on the right side. Okay.
In view of high suspicion of pneumothorax, USG point of care ultrasound was taken, which was showing absence of lung sliding on the right side. It also showed presence of lung point and absence of normal, and on M mode there was absence of normal seashore sign and presence of barcode sign.
Okay. Evin, call Evin. What all things will you see in ultrasound chest? How will you do ultrasound chest?
Ultrasound chest, first we have to see for, we can see for any pleural effusion. We can see with the, and also we can see for any consolidation changes, which are a state pattern. And also we can see for the lung sliding with the vascular probe. With the superficial probe we can see for lung sliding. And with the mode we can confirm the finding. If it is a pneumothorax, we will see a barcode sign instead of the seashore sign.
So which all points will you do ultrasound? Which all points will you keep the ultrasound probe in a chest?
When we have to see initially at the infraclavicular level, then the mammary level, inframammary level, then the axillary and infraaxillary level. And also we can look for the scapular area.
Now, where all will we keep the ultrasound machine probe?
And for pleural effusion, we have to keep at the
Which all are the main 3 points?
Main 3 points would be the lower neck.
How will you identify the PLAPS point for ultrasound? So we will be keeping the hand, we will compare our hand with the patient's hand. So if the patient's hand and our hands are comparable, we will keep both of our hands just below the patient's clavicle, which all side we are planning to do. And when we are keeping, we will overlap both the thumbs. Thumb is not included, mainly our 4 fingers are included, and we will keep it below the patient's clavicle. And we will select the middle point, middle of this hand and middle of the other hand. This is the middle part of both hands. These are the main 2 points which will be selected for ultrasound. So the upper zone and the mid zone. And for checking the posterior aspect, we need to take the corresponding posterior point of this point. Corresponding posterior of that is the PLAPS point. Whatever positive, that is the posterior, it will somewhat correspond to the posterior axillary line. These are the 3 main points which we will have to do. So, what probe will we use for ultrasound? Mostly the vascular probe. Okay, so suppose if you are keeping the, what is the normal lung ultrasound changes that you will see?
Lung sliding will be present in a normal lung.
Lung sliding will be present. So what is the normal ultrasound chest called as? What sign?
Seashore.
Bat wing.
Bat wing.
Bat wing appearance. So when we are keeping the probe, both sides you will be seeing the rib shadow, and in between you will be seeing the lungs. So that is the bat wing sign. So what else is seen? So the bat wings are both ribs are called as the wings of the bat. Then what else is seen in the lung fields? We will be seeing the that intercostal muscles, then the pleural line, then below that
Lung parenchyma.
lung parenchyma, which is sliding, normally moving. Then
We can even say like if there's any break in the B lines.
B lines are abnormal. What is a normal line seen?
A line.
A lines. What are A lines?
A lines is the horizontal lines.
Horizontal lines. Why is A lines coming in an ultrasound chest?
Because of the parenchyma, like bronchial.
There is a pleural line which is there. That it is a replica of the pleural line which is coming down. So it is not actually a line as such. It is a replica of the pleural line. All the A lines will be equidistant from each other, and it is a normal finding. That is A line. Okay. And then if suppose there is a fluid in the chest, what will you see when you are keeping the same probe?
Fluid
Pleural effusion.
Then we will see that difference between diaphragm and the lung area.
No, if you are keeping the vascular probe, the same vascular probe.
We see hypotropic or anatomic.
We will be seeing a black area of fluid will be seen. What is that called as? What is that sign called as? Fluid we will be seeing in between the muscles and the lungs. So that area, what will it be called as? It will be mostly looking like a quadrangle when we are using the vascular probe in between both this area, black area. That's called as a quad sign. And if you are keeping in a M mode, you will be seeing that quadrangle, that black area will be moving like this along with the lung sliding. That is called a sinusoid pattern. So black area along with that movement, it is called as a sinusoid pattern. Okay. So what is the normal, if we keep M mode in an ultrasound, what is the normal thing which is seen, which is normal?
Seashore.
Seashore sign. So what is sea, what is shore? Jarin. No.
C is the plural.
C is the pleura, which is on the top. That is not moving. That's why it is shown as a straight line. The lung is moving. So that will be the shore. That will look like sands and dot things. So up is the sea, down is the shore. Okay. So that is why in pneumothorax, patient is not having lung sliding. So everything will look like a sea only. That is otherwise called as stratosphere sign or barcode sign. Okay, then what are the other lines seen other than A lines? B lines. What are B lines? What is the other name of B line? Comet tail sign or? What else? Comet tail sign or we can call a lung rockets. Okay, when will it be seen?
In the parenchyma, the fluid
If there is any air fluid level, if anywhere there is an interaction between an air and a fluid, we will be seeing this lung rockets. Okay. So there is another line called as Z line, which is comparable with the B line. It will be looking like a rocket itself. So anyone has any idea about Z lines? So some patients, in normal individuals, instead of B lines, we will be seeing Z lines and we will be mistaking it as B lines. So Z lines are actually lung rocket-like lines, but it usually comes in normal individuals, and what change you will see is that it will not end till, normally B lines will be seen till the end. It will be coming and going, it won't be till the end, and usually whenever there is a patient is having a B line, that A line won't be seen. So usually this Z sign will not be till the end, and A line will be preserved. So that is Z line, and which is normal. And another line is there called as E line, which is also looking like a B line, but it is arising from the lung in muscles itself. It will be seen from the muscle area, not from the pleural area, and it will also end. It will not last like a B line. B line will be till the end. Okay. So how many B lines are considered abnormal? More than 3 in lung fields. Okay. Then what will you see if there is a pleural effusion? Fishtail sign. You are telling fishtail sign. You will be seeing that is what is fishtail in a pleural effusion?
Collapsed lung.
Collapsed lung. That will be mostly seen in a severe or massive pleural effusion. What if the patient is having only little pleural effusion?
You can see that the pleura and the parenchyma, that's space.
Fluid we can see, and when patient takes a breath, we will see that the fluid is getting covered by the lungs. That is called as a curtain sign. Curtain sign. So we will be seeing fishtail sign if it is the lung is collapsed. If the lung is not collapsed because of small effusion, we will be seeing curtain sign. Okay. Then what is C line? C line. C line. C is for consolidation. C is for consolidation. So usually, what will you see if the ultrasound, if there is consolidation, what will you see? Starry sky sign, or we will be seeing that the lungs will be appearing like liver. That is called as consolidation. So in that we will be seeing the C lines also. Other than the B lines, we will be seeing the starry sky. Otherwise, it will be showing as a C lines. Or else it can be called as tissue-like sign or shred sign. Okay, these are the things which will be seen. And what all things will you see in a pneumothorax journal? Pneumothorax ultrasound, absent lung sliding, then M mode, stratosphere sign, then lung point, when will you see?
In pneumothorax.
Pneumothorax is a very rarely. What is lung point? Transition point between the normal parenchymal area and the point where the pneumothorax is there. Okay, so this patient, that
Lung point was present.
Okay.
Ma'am, after this, chest X-ray was taken, and meanwhile ICD materials were arranged. X-ray was showing bilateral pneumothorax, right more than left. The interpleural distance at the hilar level on the right side was 4 cm, and on left side it was 1 cm. Okay. History.
X-ray, what was finding one more time?
Ma'am, bilateral pneumothorax was present, right more than left. Right side, the interpleural distance was 4 cm, and on left it was 1 cm.
Okay.
History. 34-year-old female, known case of ILD, most likely due to autoimmune causes. Known case of old pulmonary TB, hypothyroidism. Had complaints of chronic cough and dyspnea on exertion since 2 to 3 months, which progressed in the past 1 week, and followed by sudden breathing difficulty since past 2 hours. There was no history of any fever, palpitations, no chest pain, no orthopnea, no PND. On general examination, she was conscious oriented, no cyanosis, icterus, clubbing, lymphadenopathy present. On examination of respiratory system, on inspection, there was decreased chest movement bilaterally, right more than left. Trachea was appearing to be mostly central. On palpation, tactile fremitus and vocal fremitus was absent on the right side and decreased on the left side. There was, on percussion, hyperresonant node was heard, and on auscultation, bilateral air entry decreased, but on right side the air entry was absent, and on left side it was decreased, along with some basilar velcro creps were heard. Other systems were within normal limit. At this point, ICD was placed in the 5th intercostal space anterior to the mid-axillary line.
In the right, which side?
Right side. Only right side. And while the patient was also
what
kept on
type of pneumothorax is this?
Ma'am, this is secondary spontaneous pneumothorax.
Why you call it a secondary? Because
Underlying ILD was there since 2 to 3 months. She was having features of ILD.
So when all will you tell it as secondary?
Ma'am, when there is some underlying lung pathology present, most commonly COPD, followed by then ILD, infections, pneumonia, malignancy.
Then age.
This
patient's age is younger age. Otherwise, age more than 55 years, smoker and all, we will be mostly categorizing as secondary. Okay. Then when all will you consider, so we have 3 management. Either we can discharge the patient, or we can give oxygen and observe, or we will be aspirating, or we will be inserting the ICD. So how will you make a call regarding that?
Ma'am, according to the British Thoracic Society guidelines, if there is a primary spontaneous pneumothorax and the size of the pneumothorax is less than 2 centimeter, or the patient is asymptomatic, then we will only keep the patient for observation and patient can be followed up on OPD basis. If the size is more than 2 centimeter and the patient is having symptoms, then ideal first step will be to aspirate needle aspiration, followed by, if the patient not improving, then chest tube drainage.
Okay, so where will you aspirate?
Ma'am, aspiration will be done on second intercostal space, mid clavicular line. Second intercostal.
How much can you aspirate out maximum? Maximum how much air can you aspirate?
2 liters.
Up to 2.5 liters. 2.5 liters. So in case of pleural effusion, how much fluid can you aspirate toward maximum? Maximum 1.5 liters. If it is an effusion, maximum 1.5 liters. But if it is a pneumothorax, we can aspirate up to 2.5 liters. Okay. And that is from the mid-clavicular line in the second intercostal space. Okay. Whereas, where will you put ICD?
Ma'am, ICD will be placed in fifth intercostal space, anterior to mid-axillary line in the triangle of safety.
So, when all will you put ICD?
Ma'am, ICD ideally has to be placed, if it's a secondary spontaneous pneumothorax and the size is more than 2, then ICD definitely has to be placed. Then if primary and not resolving on needle aspiration, then we have to place ICD. In case of bilateral pneumothorax, it is ideal to put ICD. Then recurrent ipsilateral pneumothorax, we can put ICD, or what else? ICD.
Okay, so which all cases of secondary pneumothorax, if it is a secondary pneumothorax, when will you consider aspiration? Depending on the size.
If size is less than 2, then first we'll consider. If the size is less than 1, then the treatment is mostly high flow oxygen. If it is from 1 to 2, then first we will try to aspirate the air. If it is resolving after that, if it has now decreased to less than 1, then we can put on oxygen. But if not resolving, then ICD has to be placed. If it is more than 2, then ICD definitely has to be placed.
Okay. So, so this patient, it was placed on the right side.
Right side.
And the left side, what was done? Nothing.
Nothing, ma'am. 1 centimeter. High flow oxygen was there.
Okay, okay. Then what happened?
Ma'am, then repeat chest X-ray was taken to see the position, and it was showing a resolution of pneumothorax as compared to the previous X-ray. Also, ma'am, CT chest was, patient was admitted in pulmonology, and CT chest was done to look for the disease progression, ILD disease progression. So the disease had, like, it was showing fibrobronchiectatic changes in upper lobe. The disease had further progressed, and then actually after few serial X-rays were taken, it was showing resolution. ICD was clamped.
And what about the other side?
Both side resolution. Yes, ma'am.
Okay, okay.
And ICD was clamped for 24 hours, and patient was improving clinically. After that, ICD was removed, and after rheumat consultation, patient was discharged on low dose steroids for ILD.
Okay. So what are the other causes? So this patient, we know ILD is a cause of this pneumothorax. What are the other causes of pneumothorax?
Most common will be COPD or any obstructive lung disease, asthma, then bronchiectasis, then ILD can be a reason. Malignancy, primary malignancy or lung metastasis. Infection, pneumonia, necrotizing pneumonia can cause pneumothorax. Connective tissue disorder, Marfan syndrome, genetic predisposition can also be there, Marfan syndrome or Ehlers-Danlos syndrome. Then rheumatoid arthritis, ankylosing spondylitis, polymyositis.
Okay. So in an ER, when a patient presents with these symptoms with absent air entry, either we will do an ultrasound or we will do an X-ray. So X-ray findings of pneumothorax, what are the X-ray findings, Evin? What are the X-ray findings of pneumothorax, Evin?
Pneumothorax, we will see the bronchovascular markings abruptly stopping and won't be going to using centrally. And also it will be a red black in color. And the lung border will also be visible and collapsed state. And the trachea will be deviated to the opposite side.
Okay, so how will you know whether it is an AP X-ray or lateral AP or PA X-ray? Jarin, how will you know if it is an AP X-ray or a PA X-ray? Chest.
Looking on the heart, we can see the clavicle also we can.
So by looking at the heart, what will you see?
Supine position heart will be very enlarged.
Supine position, AP. There will be apparent cardiomegaly. What is the normal heart size which is expected?
Less than half of
Normal heart size in an AP X-ray is less than 50% of the transthoracic diameter. Whereas in AP there will be a apparent cardiomegaly seen. Then how will you differentiate AP and PA?
Basically ribs which will be
Then in a AP X-ray mostly we will be seeing the gastric bubble which won't be appreciated in a AP. PA we will be seeing. Then PA will be mostly taken in a standing position by the patient will be little bit bent forward like this. So what will be there? That scapula will be away from the lung field. But in a AP, that is in a PA. AP, the scapula will be seen just behind the lung field. Just behind the lungs. So whereas in PA it will be away from the lungs. Okay. Then so how will you read a chest X-ray?
First we need to identify the structures like anatomy of the trachea.
Before identifying structures, what will
is the exposure of the comment on the exposure.
Before commenting on exposure.
whether it is complete or
Name and age. Then we will have to tell AP or PA. Then
Exposure, proper pure exposure. Then we can comment regarding the anatomical structure.
before that, rotation. How will you know if it is rotated or not?
Distance between the interclavicular we measure from
Both sides should be compared.
Spinoclavicular lines from the spine. From the spine, whether it is equidistant or not. Then after looking that, then anatomy, what all things will you look?
trachea central.
Trachea.
Then any bony
Skin, soft tissue.
Either from in to out or out to in. So if you are looking from in to out,
first trachea.
trachea.
Then
3 H's we can look. Heart, whether it is, what is the size of the heart. Then we will be checking for the aortic knuckle, the pulmonary veins, and these things will be looked. Then other H is hilum. Which hilum will be up? Right hilum or left hilum?
right.
Left hilum will be up. Left hilum will be somewhat 2.5 cm above the right hilum. So hilum we will be checking. Then another H. horizontal fissure, right? Horizontal fissure which will extend from the hilum over the right side towards the sixth rib. So what all things? Heart, hilum, horizontal fissure. Then what else? Then towards the lungs. Check the lungs field, then the trachea, then the rib shadows, soft tissue, then down. Coming down, what all things will you check? Diaphragm. Which diaphragm will be up? Right. Right will be up. Because of the liver. What is the normal expected difference between the height of both the diaphragm? Up to 2.5 centimeter. If it is seen as more than 2.5 centimeter up, then we should suspect some kind of a diaphragmatic palsy or something. So maximum up to 2.5 centimeter. Okay. Then what else? Costophrenic angles. When you are coming down, costophrenic angles, whether it is blunted or normal, and whatever abdomen you are able to see, any air under the diaphragm and the bowels, and these things should be checked in an X-ray. Okay. So, as I been told, we will be seeing a collapsed lung and also translucent sign in case of a pneumothorax. So, when will you tell it as a tension pneumothorax?
Ma'am, on X-ray, if there is mediastinal shift, or if there is depressed diaphragm, or if there is expansion of rib cage, these three things will be there in tension pneumothorax. Clinically,
and trachea will be shifted.
Trachea will be shifted.
Clinically?
Ma'am, clinically patient will present with patient will be unstable with hypotension, patient will have tachypnea, tachycardia, hypoxemia will be there, ABG can show hypoxemia and respiratory acidosis.
Along with the tachypnea and tachycardia, what else will be there?
Hypotension, a distended neck veins will be there.
Okay. So when so this patient an ICD was placed. This patient was not in tension pneumothorax, but indication wise more than 2 centimeter was there in an X-ray. That's why an ICD was placed. So when will you consider definitive management for pneumothorax? Like if there is recurrent pneumothorax and all.
Ma'am,
what are the options?
Ma'am, surgical options, definitive management will have either fluorodesis or surgical options. Surgical will have like open thoracotomy or VATS procedure via which we can do pleurectomy or bulectomy. This will be indicated mostly in patients who are either having persistent air leak. Even after placing ICD, air leak is present for more than 4 days. Then if there is recurrent pneumothorax, in patients who have high risk occupations like patients who are pilots or divers, they can get recurrent pneumothorax, so their definitive management will be considered. That's it.
Okay. So what advice will you give this patient at the time of discharge?
Regarding air travel, we can tell not to travel for 3 months, 3 to 3 months.
Okay. So this patient, any definitive management was done?
No, ma'am. She improved without that.
Okay.
This was the first time she was having pneumothorax.
Okay. And patient got discharged. Okay. Thank you.